Okay, great. Okay, thank you very much, Dr. Muharib, for this introduction. I'm going to jump in right away to see, without further ado, we're going to talk about the pathophysiology of sickle cell disease. And as just Dr. Uthman, mashallah, tabarakallah, explained it to us very well, it's a point mutation happened with the 6 amino acid position and give a rise for a mutant hemoglobin called hemoglobin S. And upon deoxygenation, what happens is the polymer formation happens, and then that poking the cell membrane give us the known sickle shape that we know. The sickling itself is dependent on the concentration of deoxyhemoglobin S. This is a study from 1947 where they measured what we call the delay time. The delay time is the time between deoxygenation and polymer formation. For that, they utilize different concentration of free hemoglobin S. Sorry? They utilize different concentration of free hemoglobin S, and they measured the delay time, and they saw that a very short delay time was observed when a higher concentration was used, and vice versa. When a lower concentration of the hemoglobin was used, then the delay time was up to 1 minute, which is a very, very critical time because the cell can just trespass the microvasculature bed without causing the vasoocclusion crisis. So that got us to think, how can we therapeutically manipulate the mean corpuscular hemoglobin concentration? And then there's a case of iron deficiency patient with sickle cell disease. And Dr. Castro, who published this case report in 1983 in New England Journal of Medicine, he measured the RBC survival in this patient. And he showed that 50% of the RBC survived in the iron deficiency state up to 16 days. This is quite remarkable in sickle cell disease, where the half-life of the red cell is about 5 to 10 days. Then after the iron supplementation for this patient, the RBC survival went all the way down significantly to 5 days. But it's also worth mentioning here that the MCHC in this patient was 30.5 gram per deciliter and then increased up to 37 gram per deciliter. So our project is about to have to use the dietary approach or the iron deficiency as a potential treatment for sickle cell disease. The significance of it, well, first of all, sickle cell disease is the most common hemoglobinopathy in the world. On the other hand, iron deficiency is another top cause of anemia. It's the top cause, by the way. Both of them are highly prevalent in developed countries. And from several case reports, not only that one that we just mentioned, iron deficiency has a potential as a treatment for sickle cell disease. And in limited reports, we saw that supplementing iron in sickle cell disease as well as malaria exacerbate the complications. So by far, this was the first preclinical study to systematically examine the effect of iron deficiency as a treatment option in sickle cell disease. For that, we utilized a transgenic mouse model of sickle cell disease called the Towns mouse model. In this mouse model, the hemoglobin or the alpha and beta in the mouse was replaced by humanized alpha and beta and gamma. So we ended up having humanized hemoglobin in red cells. So to induce iron deficiency, we used two diets: the iron-restricted diet that has 0 to 3 parts per million iron, and the control diet that has 39 parts per million iron. We have a total of 60 sickle cell disease mice, equally distributed among two sexes, males and females, and we equally distributed them into the two diets. At each time point, we have 2, 4, and 6. We sacrifice the mice, 20 mice of them, and we collect blood and other organs for the measurements. For statistical analysis, we run the multivariate analysis because we have 6, we have the diet, and we have 3 time points. So we have multivariate here. We did 2 key postdoc for some of the measurements here too, and chi-square test for the categorical variables. So to ensure that our diet is working, first of all, we measured hepcidin, which is the iron regulatory hormone. And we saw that, and mentioned here, that the x-axis is a logarithmic scale. So what we saw here, that what is also known about hepcidin is in cases of iron deficiency, hepcidin gets suppressed, and in cases of iron overload, hepcidin goes all the way up just to close the ferroportin on the cells. So we saw that iron deficiency was able to suppress hepcidin in the iron-restricted groups, or in the mice that fit the iron-restricted diet. Then we went ahead to measure the ferritin, the body iron stored in these mice. Generally, for ferritin, it's quite high, as just Dr. Uthman showed us in his presentation. Ferritin is quite high in hemoglobinopathies, and it's quite high also in sickle cell disease. But nevertheless, the dietary iron restriction was able to lower the ferritin level significantly across all time points in these mice. We went ahead and we want to know what happens at the RBC parameters level. And not to go and mention about all the CBC markers that we had, we are focusing here on three things. Hemoglobin, which is the total hemoglobin. And we see, as we see with any iron deficiency, the case is hemoglobin is getting lower. And this is what we saw here also. The diet was able to significantly lower hemoglobin in all these mice. What we also measured here, which is the marker of interest, the mean corpuscular hemoglobin concentration. We want to know if our diet can significantly lower this concentration inside the cells. And we saw that the p-value is equal to 0.05. So we are showing only a trend of decrease in this, but not significantly. When we take it to see if there's a gender specific between these mice, and we saw yes, male are more prone to be more significantly lower in the concentration of hemoglobin than the females. We took it ahead and we want to know the marker of iron-restricted erythropoiesis, such as the reticulocyte hemoglobin equivalent. This gives us the assessment of the iron incorporation into the erythron. And given the time that the reticulocyte is only going to be there in the circulation for 1 to 2 days, it's very important to measure the erythropoietic activity. So we saw that with the iron restriction, there is no significant decrease in reticulocyte hemoglobin. But again, when we measured the cellular hemoglobin level, which is reticulocyte here, we saw a male-specific decrease. We went ahead, according to other reports in 1975 and 1983, where iron deficiency and sickle cell disease might increase the hemoglobin oxygen affinity. And we took it upon ourselves to see if this is true or not. So we measured the hemoglobin oxygen affinity. We generated the hemoglobin oxygen dissociation curve using HEMOX analyzer. And we saw that, if you remember that the sigmoid shape that we have, we shifted the sigmoid shape to the left, meaning that dietary iron restriction was able to increase the oxygen affinity. And we will measure the partial pressure of oxygen where 50% of hemoglobin was saturated. We saw that the P50 was lower significantly in males and females fit the iron-restricted diet. We moved ahead and did the sickling assay, which is the ability for the cell to sickle in a hypoxic condition. We used for that an automated microscope, and we diluted the cells that we have from these mice in a 384 well plates. We incubated them in a hypoxic condition in this automated microscope that can maintain the temperature, humidity, and the atmosphere for 12 hours. And then a picture was taken every 15 minutes. And not to go into details and elaborate the 19,200 images from each plate that we analyzed using Gen 5 software. But at the end, we plotted this in a one phase. This is a video just to show you how the cells behave under the microscope in that period of 12 hours. I'm not going to go for 12 hours here, just only 6 seconds. So all the cells starts as round, and when we go moving forward, nearly all of them sickle. And the sickling phenotype itself is a little bit weird in the mouse. And when we plotted that in a one-phase exponential decay, we were counting how many red cells remained round all the way down to 12 hours. And we saw this is only a representative graph from all these experiments, but we showed that the iron restriction could slow the rate of sickling in these mice with a p-value less than 0.02. So knowing that we have decreased the concentration, knowing that we also have increased the oxygen affinity, knowing that we have slowed the rate of sickling in these mice by iron restriction, we went ahead and measured the hemolysis marker. And in the mouse, we measured the absolute reticulocyte count, which is a surrogate marker for hemolysis and vaso-occlusion crisis in sickle cell disease patients. And we showed that iron restriction could lower the absolute reticulocyte count in these mice across all time points. And then we measured the plasma heme in these mice. And we saw also as a marker of intravascular hemolysis, so we showed that iron restriction could lower the plasma heme concentration in these mice across all time points. We went ahead and took the tissue from these mice, liver, spleen, and kidney, and we stained them for Pearl's iron stain to see the iron deposition. We categorized that as 0 to 1 to have minimally or rarely observed deposition, 2 for occasionally, 3 for abundant, and 4 for severe. And we compared with them in each tissue that we have, and we saw that iron restriction significantly lowered the iron deposition in these organs, in spleen, kidney, and liver. One of the well-established feature in this model, and also a known complication in sickle cell disease patient, is the hepatic necrosis. And this is a liver cross-section from the left from a mouse in the iron-restricted diet. Shows no evidence of hepatic necrosis, although we appreciate that there's an inflammatory response in the background. But on the other side is a liver cross-section from a mouse in the iron-sufficient diet. And the yellow arrow here is pointing out to the multiple foci of hepatic necrosis. For that, we measured if hepatic necrosis is present or not. And we did chi-square for it and multivariate analysis to show that. And we saw that with the p-value 0.02, that there are 4 times greater chance to develop hepatic necrosis in the iron-sufficient diet. To end it up and wrap that in a model.
Oh, please.
Yes.
We exceeded your time, Majid.
Okay. With the higher MCHC, there's a lower hemoglobin oxygen affinity, and it could fast the rate of sickling. Then that might give the hepatomegaly and the data for it is not shown in this presentation, but the hepatomegaly and developing of hepatic necrosis with severe iron deposition because of the increased obstruction and vaso-occlusion that happens here. Without iron, the reduced MCHC may improve the hemoglobin oxygen affinity, which in a way that could lower the sickling rate and gives less hepatic necrosis incident and normal liver phenotype by reducing the obstruction and vaso-occlusion in these mice. And one of the reasons is to have a minimal iron deposition. Not to mention that, but if we have a Q&A for it, we can elaborate on it. The take-home message is the evidence from this project support the hypothesis that iron restriction is protective in sickle cell disease. And warrants further studies in human research subject. The iron supplementation in sickle cell disease is a controversial area. While it may be necessary in cases of established iron deficiency, it's unlikely to be helpful given this indiscriminately. In fact, iron supplementation could worsen sickle cell disease by increasing sickling and hepatic necrosis as shown in this preclinical model. Conversely, limiting iron intake of iron merits evaluation in people with sickle cell disease. The dietary approach is simple and inexpensive and could be scaled up with minimal expense at once. The safety of this approach is first established.